So yeah, hi, I'm Chuck Kanaly. I'm a neurosurgeon in Fall River, Massachusetts. And so I just kind of wanted to go through somewhat my journey and how I've kind of fallen into the robotics. I didn't really plan on this 10 years ago at all, but it's just kind of happened organically as time has gone on. And so I kind of wanted to impart to you somewhat, how my practice has changed over the years ever since starting with robotics. So I have a few simple disclosures. Since I started with Globus, I used to be a consultant with them. I haven't done any work with that really in the past over a year, but I do still have some ongoing industry-funded clinical outcomes research, which I might mention briefly, but I haven't really put it in here in detail. So there's just an overview of what I hope to cover. So I want to talk a little bit about how my practice was before starting with the robot, just kind of where I used to be. And then since starting with the robot, we actually got the system back in late 2017. And so since then, kind of how we started and then what that's caused me to change in my practice over the last 4 years. And I hope to try to convince you that robots, the robotic system is kind of an enabling technology that basically has allowed me to expand my indications for surgery. Because even though I'm at a fairly small community hospital, we're able to do a lot more with it than what I wanted to do before. And it's also kind of had me switch. I didn't really plan it this way, but my practice has switched from being mostly open cases to mostly minimally invasive, and it's mostly just because of ease of minimally invasive procedures with the robot and the improved outcomes that we've been seeing with patients. So just a little background about me. So yeah, I'm a private practice neurosurgeon in Fall River, Massachusetts, kind of along the south coast of Massachusetts, just next to Rhode Island. It's a fairly small community hospital. And pretty much I see degenerative spine conditions. So not a whole lot of trauma at our place and not a whole lot of tumors or anything either. So it's mostly just kind of standard degenerative conditions. And previously, by and large, most cases were 1 or 2 level fusions. If I was doing a fusion, it's usually a smaller, for a stenosis, spondylolisthesis, just something fairly standard. And my training at Duke was in both open and minimally invasive techniques. And at that time, it was pretty much all fluoro-based techniques. So I was trained in doing both of those. But certainly before the robots, by and large, almost all my cases were open. I very rarely did minimally invasive cases. And there was a number of reasons for that, but mostly I found the open cases to be much more simpler. It was a lot easier than having to deal with moving fluoro machines back and forth all the time, didn't have K-wires. It was a lot faster for me in my hands. And certainly you could see things a whole lot better. I had better control, I felt, over where the screws went in. And I felt like I had a better grasp of what was going on in the surgery. And certainly it was a lot less radiation in the OR. So on the minimally invasive TLIF cases I used to do, fluoro, that was my highest radiation case by and large of any surgery I did. A lot of intraoperative radiation checking with the x-rays. And I do feel like on the open cases back then, I had much more control over where my screws were placed. I could make sure I was avoiding the adjacent level facets. I could change my starting points a lot easier when I'm directly seeing it to line up for rod placement and things like that. Whereas with the minimally invasive, you're just looking with the fluoro, you don't have quite as good of a hold over where exactly that screw is starting. Are you touching that facet joint? Are you, where does the screw head end to line up for the rod? So it seemed like there was a lot more torque on the screw heads trying to get the cap screws on and things. Since starting with the robot, as time has gone on over years, I've gone to almost completely minimally invasive surgeries, very rarely do an open now. And it's even gotten to the point where we're doing more complicated explorations and revisions, minimally invasive. And like I said, I wasn't a classic minimally invasive guy at all before. Now we're actually over 600 of these cases. And I don't think I do that in many per se per week. It's just we've had it for a long time. It's been 4 years now since starting with this thing. And the way I've kind of approached the robot is ever since we got it, every single thoracolumbar fusion I've done with the robotic system. So I know some people kind of approach this and say, oh, well, this is a neat tool to use on hard cases. I really wouldn't recommend that. We use it on every case. And so it makes those hard cases easier by doing it on the easy cases also. And I've, even since the beginning, we haven't had any bailouts where I had to give up on the robot and just do it the old way. We've made it work on every one. So I can say I haven't put in a standard pedicle screw without the Globus system since our first robotic case 4 years ago. So I honestly, I'm kind of losing touch with all that training I had, because it's pretty much all been this new way. I want to say a little bit about workflow, since I know you guys have been touching on that a little bit earlier here this morning. The way we do it at my place is once they get scheduled for surgery, we book a pre-op appointment a few days before. That's standard labs, and we give them some chlorhexidine wipes and standard stuff, but also we get our robotic CT at that time. So I'm at a small community hospital, so we don't have a big intraoperative C-arm or any too much fancy stuff. We do have this robot, which I love, but we don't have too much else that goes into it. So we get the robotic CT right before. And so I do want to have it within a month, but ideally we typically get it within a few days before, just to make it as accurate as possible. And I don't spend a whole lot of time with the planning way in advance. So since we just get that scan 2 or 3 days before, I do it right as the patient's rolling in the room. So we just plan it there before. It's got a pretty small OR footprint, the robot. And so we don't need a whole lot of extra fancy equipment in the room. And I can do it in one of the standard OR rooms. We just have a standard C-arm machine that we use. There's a little cover that goes over the, on the C-arm. But beyond that, there's no other real special equipment besides the trays that that Globus brings in and whatever. And in my practice, when we started, I certainly had an extra rep in there. We had one of the robot specialists in the room, and they would help at the beginning. Probably by about 3 months or so, they kind of phased out because my rep did get more experience with it. But now it's just our current spine rep who is also trained in how to do robotic cases. But frankly, I mean, they're there. It's helpful to have an unsterile hand to move some things if needed, push the robot in and out, change the little navigation tracker, things like that. But honestly, I don't feel like it would speed us up at all if I had someone more trained in the room. It doesn't really help. And we use pretty standard OR staff. I mean, I don't have a special dedicated team. People rotate through the room. They're doing the general surgery cases. They're doing the Da Vinci's, kind of like was mentioned. I mean, so we don't have one set staff. I do have some preferred people that are in the room, but it doesn't take a whole lot of extra people around. And we've still gotten our OR times down and done this pretty quickly. So I don't think there is a whole lot of infrastructure really per se at my center that that's required. In my practice anyways, I've noticed over time, and like I said, we do have some clinical studies that I'm trying to get published with a few of these things, but we have definitely put in larger screws. I'll show a case example of that later because of the robotic system. So I feel with the robot, I've been able to have much more control over where those screws go. And so typically pre-robots, we would always kind of slightly downsize the screws, maybe in the lumbar, we put in 6.5s, now I can put in a lot bigger ones because I know exactly where they're going. There's less variation in where it goes. And so you don't need to kind of undersize and give yourself some wiggle room. So we put in much larger screws than I ever would have before. And I'll show you one of those later. And so that I imagine long-term will translate into much better outcomes, less screw breaking, less screw pullout, things like that. And also you have much more control to make sure you don't hit that facet nearby. And you can actually plan it perfectly so that the rods drop right in without having any torque at all. So you can just literally softly put the cap screw in. You don't even have to put much pressure on it at all, unless you want to reduce the spondy or something. Also in over the years anyways, certainly not at the beginning, but now we have much shorter surgical times. This has really sped up the practice. And shorter post-op stays. So currently our average length of stay after surgery is 1 night. For most of these, they go home the next day. With some of these changes, I would say is because of the minimally invasive transition too, not just the robot, but the robot has kind of enabled that to happen. So much less narcotics. We've had smaller complication rates. So I actually haven't had to replace a single robot screw. So I know there's been some publications with a crazy screw here or there, but we haven't really seen that. And I do think a lot of it's a different skill set with the robot. You have to really listen to what it's telling you. So certainly you can make a robot go wrong, just like you can make an open surgery without a robot go wrong. But there's different things you look out for. So I think that's some of the learning curve. You have to know what looks off and what's funny and catch it. And because of the faster times, the smaller surgeries, we've been able to really expand our surgical indications. So we're doing surgeries on older people than we would have before, more comorbidities, larger, more obese patients with the pandemic and everything. And we've been able to do some more complicated things too, without having too many concerns at a community hospital. In my personal learning curve, I guess I'd say, here's some observations I've kind of come across. Similar to what I guess the earlier presenter was talking about, I don't see a whole lot of difference in reliability and accuracy across cases. I know they had mentioned earlier, like residents had similar placement as attendings, and same idea. I mean, I think the accuracy has been pretty consistent throughout. And I have seen that in some other big national studies that, whether you're a good surgeon or a bad surgeon, the robot helps kind of equalize some of these outcomes. Whether you're having a good day or a bad day, that screw still usually pretty much goes in about where you want it to. So there might be some minor fluctuations, but really nothing major. There has been a large decrease in operative time as years have gone by with the robot. More experience, less issues with the staff not knowing what's going on or who's supposed to be where and doing what. So I'm doing much faster surgeries now than I ever was before having the robot, but that took a year or so to happen. That was not right at the beginning. And then my preoperative plans have changed with experience too. So it's not just putting the screw about where you'd want it to be on, as if you were doing an MI TLIF with fluoro. It's you want the screw in the right spot, but now you can also plan much more finer, subtle details. I'll point those out in a case example later. So you can plan how you want the heads to line up. So you can put your rod in that way. And if you're trying to adjust or correct for something, you can put your heads perfectly so that that it'll pull back and set that angle for you. And also you can adjust your screw angles to adjust your incision planning. And even some anatomic factors that are more of an issue with robots than they might have been otherwise. So, if there's a big hypertrophic facet, you can plan where you want to avoid some of that or the perfect angle to get through it so you don't get skive. I have noticed too that over time, the prior talk mentioned that, there was some skive with some of the older drills. So I have one of these newer high-speed burrs too, and that has actually helped with some of the skive issues. And then I'd also say that the software has certainly improved every iteration. They constantly update some of these things, and it's a lot easier, faster system now than it was 3 years ago. So it certainly is getting improvements incrementally year by year. So some recommendations, I guess, I would give for this transition and to start with robots, I would say start with your surgery doing the same types of surgeries you did before. I don't think you should say, oh, well, hey, this is a hard case. Let's try the robot on this thing. You need to start with what you're used to, what you're comfortable with, and just bring in the robot as a new tool and get used to it that way. I think it's really beneficial to do every lumbar fusion with the robot. It increases the speed of you. It increases your experience and comfort with it. Also, it helps with the staff tremendously. Everyone gets used to this is just how you do fusions now. They kind of forget the old way. And I would say I actually did more open cases right when I started with the robot because I didn't trust it. I wanted to make sure I could see where that was going, make sure I agreed. Yeah, that's about, that looks right to me. Later, I transitioned to minimally invasive once you're more comfortable with it. And then you kind of know what are the warning signs, what to look out for. Hey, that drill feels a little funny as it's going through or something. And I want to give a few examples here too. So these are kind of some more recent cases, I suppose. So this was a young lady with an L5-S1 slip bilateral pars defects and minimally invasive. I was able to plan the screws on this so that the L5 screws were a little bit sunk in more than S1. And then we locked the rod on S1, pulled back on L5, and we got pretty good correction of her alignment there. That was a pretty simple one. On this one, it was an hour and a half surgical time with the robots. Again, all of these are pre-op CT, and then I plan it right beforehand during induction. And this is kind of some pictures of what we did. So those are the incisions on the right picture. That's the little DRB and the tracker probe to make sure it doesn't move. And you can see here we're just doing these percutaneous screws with the rod passer. And then I'll kind of go through a little more complicated as we go through these. So on this one, I had a patient with an old lumbar fusion from 5 or 6 years ago. It had an adjacent level slip and stenosis. And so normally this would typically be kind of a bigger open deal to try to revise that somehow, maybe have to put a longer rod in, maybe replace your old screws. or do some sort of a connector. So I've been doing these minimally invasive now because with the navigation on the robot, you're able to track where and see where you are inside. And then and it's a lot easier to plan the screws and everything and plan where you think the rod's going to fit. So for this one, I actually did an addition connector and just ran it up to the next level. And so again, this only took about an hour and a half with the robot. It's really pretty quick. And so these are some pictures of what we did. So on the far left picture, all those little dots are from the navigation from the Globus system. And so the screws are in the upper level, and we put that interbody spacer in, and you can see there's a little tube going down in between. And then the final fluoros images on the center and the right show kind of the end result. So we had a little addition connector that went over from the old rod, and then I just slid a rod to connect between that and the screws above. These are some pictures of how we did it. So the addition connector, you can actually just put it right minimally invasive. So I was checking with the navigation, we dropped it in, and then we connected it with the rod up to the next level. A few other examples here. So this is a poor lady with widely metastatic endometrial cancer. She had it in her lungs, all widespread, but she couldn't walk, and she was losing significant quality of life. So we just did a separation surgery there and tried to stabilize across the area. So again, I did this minimally invasive. And like I said, I wouldn't have done this minimally invasive 5 years ago, I guess. But now it's kind of just become so easy to do these with the robot system. So here we decompressed around the nerves, just using a tube to open up that area. I wasn't going for cure here at all because she had it all over. And so we put screws above and below and bridged the gap there. And then she could get radiation for the rest of it. But the main reason I put this case in was we were able to put 7.5 and 8.5 millimeter diameter screws in here. So that's a really strong construct. So I would have never been able to put 8.5 screws into the L4 bone before the robot. So just with the technology this allows, it really enables you to do a lot of things that you probably wouldn't have been able to get away with beforehand. And then here's another interesting case we had. This is a guy with a distant L4 to S1 fusion, was doing well with it, but then got in a car accident. And he had severe fractures at L3 and L1. He actually, both bones buckled. And at the L1 level, he had bony retropulsion with severe stenosis. So he was actually seen at a trauma center. Like I said, I don't do a whole lot of trauma, but he's an old prior patient of mine. So we refused surgery there. They put him in a brace, and he ended up coming to see me in clinic pretty quickly afterward. And so it was a little bit complicated because although this hardware was fine, to deal with these issues, you can't really bridge across L1 and stop at L2 with a fracture at L3. So we ended up having to do kind of a pretty big construct here and had to get above L1. So we went from T10 down. This hardware he has in is old Medtronic stuff. And so I couldn't really get that to talk well with the Globus. So I had to replace it. But again, I did this all minimally invasive, only about 150 cc's of blood loss. He was actually doing great right afterward, went home after 2 nights. And so this is kind of what we ended up with on him. And so we got good alignment and kind of spanned across his 2 fractures and decompressed the regions that needed it. The reason I pointed this out too is if you look at some of the screw planning on the right image, you see at the topmost level at T10, they kind of go straight in, but at T11, they're angled more down. They did that on purpose to try to minimize the screw incision. So at these levels, if you kind of angle just slightly the screws, it makes a big difference when you go back towards the skin surface. And so we could do this with kind of a few scattered small incisions instead of one stab incision for every screw head. And so that really minimized the tissue trauma. And then we could plan all these screw heads out before on the robot. And so it really made it quite simple for a minimally invasive rod in here. So we really had very minimal torque on the screw head. So hopefully that'll lessen any, future pull-out complications or anything. So that's kind of the main thing I want to cover, but certainly if anyone has any questions.
Thanks, Chuck.
Sure.
Dr. Kanaly, that's a great talk. Thank you. That's a great talk with, I love your methodical approach to things and how you kind of ramped up things in kind of your own practice, which is really incredible. And I appreciate that. I have one question. We're trying to keep us on time here, but what about in the outpatient surgery center? Are you doing any cases there? I know these are all hospital based, you mentioned, but I'm just curious what your thoughts are about that.
I haven't taken that step. I mean, there are people that have wanted to go home like 6 hours later. When you do these little small things, I mean, they usually bounce back pretty quickly. We also do a lot of, perioperative medications that help, some in pre-op, and then we're injecting a lot of local medication in the area. I probably could get some people to do that, but we haven't bothered trying to bring the robot to other places. It kind of just lives there. So I haven't tried any same day discharges. I think I might have had a handful of people that did want to leave, but we haven't really pushed that envelope yet. Probably could.
Well, I'm just kind of wondering, well, I'll probably poll the audience later. We recently did one, which I'm encouraged by it because I think it certainly lends itself to it. But anyway, thanks for a great talk.